Good morning and good afternoon. My name is Tracy Cook and I'm with Sachs Healthcare Communications. Before I introduce our moderator, James Simmons, and our speakers, Nicole Kupchik and Dr. Ben Abella, I'd like to show our audience how to send questions and comments. You can type your questions directly into the questions box. Today, our moderator is Dr. James Simmons. Dr. Simmons is currently a hospitalist nurse practitioner at St. Francis Medical Center in Los Angeles, California. He is a guest lecturer at both the UCLA School of Nursing and the University of Illinois Chicago College of Nursing. He is the clinical ambassador for the CDC's Let's Stop HIV Together campaign and continues to emerge as a leading nationally recognized voice advocating marginalized communities in healthcare. Dr. Simmons is also frequently featured as a health expert on national television, radio, podcast, and social media programming. James, welcome.
Thank you very much, Tracy, for that awesome introduction. Appreciate it. And good morning, good afternoon to everyone out there watching. All right, so the title of today's webinar, super cool, haha, pun intended. Too cool or not too cool? What defines high quality post-arrest care? Very topical. So speaking today on this very topical topic are two outstanding speakers, Nicole Kupchik and Dr. Ben Abella. So Nicole has practiced as a critical care nurse for more than 20 years and is currently also a clinical nurse specialist. Nicole is the author of 6 certification review books and has published numerous papers on resuscitation topics, including a paper published in September 2021 on post-arrest care. You're getting the experts here. She's a former Code Blue committee chair and resuscitation consultant, a contributing editor for the American Journal of Nursing, ECG Strip Savvy, and a highly sought after speaker. Nicole has presented at numerous national and international conferences, and she's just an amazing person, by the way. So hello, Nicole, say hi.
Hello.
Kisses, blowing kisses to everyone. I love it. Okay, so our second speaker now, Dr. Ben Abella. Dr. Abella is the Vice Chair for Research, Department of Emergency Medicine at Perelman School of Medicine, University of Pennsylvania. He's the Director, Center for Resuscitation Science, say that fast, and Medical Director, Penn Acute Research Collaboration, or PARC. He has published, ready, more than 200 scholarly works, reviews, and monographs in numerous professional journals, including New England Journal of Medicine, Journal of American Medicine, and Circulation, as well as textbooks chapters on cardiac arrest and resuscitation. He's the co-chair of the Global Resuscitation Science Symposium and has participated in developing international CPR guidelines. He, of course, has also lectured widely on the topics of cardiac arrest and post-arrest treatment. We promise you, we're giving you the best here. Dr. Abella, say hi.
Hi, everybody, and apologies. My emergency medicine lifestyle is such that sometimes my location doesn't work out. I'm coming to you live from my car, but I'm parked safely and on good audio, so I look forward to having an engaging conversation with all of you.
I love it. We promise that Dr. Abella is not going to drive during this presentation or anything, okay? We parked him in a car for this. Very good. Hey, this is the world and the reality we're living in right now. So I'm glad that we're living that real thing. And really, in real life, there are some disclosures that our speakers do have. So Nicole is part of the Speakers Bureau for Stryker Medical and Baxter Healthcare. She's also a consultant with Baxter Healthcare. Dr. Abella, his disclosure, Speakers Bureau for Stryker Medical, a consultant with Becton Dickinson, and equity shareholder of VOC Health. Okay, so for everybody watching, and there are a lot of you out there, this is good for continuing education for nurses and respiratory therapists. Super awesome. It's approved for 1 contact hour, and a link to obtain your CE credits will be available at the conclusion of the webinar. We'll kind of go through exactly how you're supposed to get it and where the email will come from, all that stuff, okay? A big support. They're supporting us. A big thank you to Stryker for supporting this educational activity. All right, so those particulars are out of the way. Remember, we'll have questions at the end. We'll also tell you how to get your CE credits at the end as well. But for now, I'm gonna shut up and I'm gonna pass it on to our experts, Nicole and Benjamin.
Yes, well, I want to say a huge hello to everyone and thank you for joining us on this fall afternoon. But again, we're going to talk about too cool or not too cool after cardiac arrest. There's been some recent data published that really, I think has maybe led to some confusion, like which direction do we go? What does the data show? And so Dr. Abella and I really want to make this conversational and just talk through the literature and talk about just some different options that we all have for that post cardiac arrest patient. And like I said, we really want to make this conversational. So you're going to hear Dr. Bell and I have known each other for years. How many years? We were talking about this the other day. It's been like over
Well,
16,
it's got to be at least a decade. Yeah, 15 years, something very long. And I would say Nicole and I also have been deeply involved in the cardiac arrest and post-cardiac arrest world, therapies, protocols. We've worked with many hospitals together. So we are truly warriors in the cardiac arrest arena together.
Yeah, absolutely. Yeah. And so, you know, we want to make this conversational. So you might hear Ben and I being a little on the little informal, but that's just because we want this to be, we want you to walk away with something. So we're going to talk about the recent findings of the TTM2 trial, as well as the Hyperion trial, which was published last year. And then we're going to talk about just the concept of tailoring therapy to a patient who's had a cardiac arrest. All right, so here's our case. You've got an ambulance that arrives with a 57-year-old male who's in cardiac arrest. EMS gives reports saying that the patient collapsed at home. The wife witnessed the collapse. She performed bystander CPR until EMS got there, and there were no known pre-arrest symptoms. So EMS found the patient in ventricular fibrillation. They shocked the patient, unfortunately was unsuccessful, and brought the patient to the emergency department. Currently, so as the patient's brought to the ED, the patient is pulseless. They're in a fine ventricular fibrillation arrest. Epi was given, they were intubated, CPR is ongoing. After more defib attempts, we got ROS, or return of spontaneous circulation. However, the patient remains comatose. Do an initial CT just to rule out head bleed or any trauma. It's all negative. ECG does not look like the patient's having a STEMI either. So the patient is planned to go to the medical ICU. All right, so that's our patient. So Tracy's going to launch a poll and just kind of given that situation, it was a witnessed VFib arrest, got bystander CPR by the wife, patient still remaining comatose now that we have return of spontaneous circulation. So you want to get an idea from you, like what would you do in your facility? Would you implement targeted temperature management with a target of 32 to 34? Would you implement TTM with a goal of 36? Would you just maybe avoid fever, or would you just do usual care where you wouldn't provide cooling, or temperature management? So get your votes in. Let us know what you would likely do at your facility, and then we're going to talk through the literature. All right, Tracy, are the votes rolling in?
They are. Let's give them a few more seconds. And again, you can respond directly onto your monitor, your screen.
And while they're voting, I would just point out that this question is one of the most hotly discussed questions right now in the global resuscitation community, not just in the U.S., but in Asia and Europe. I mean, this is really the hot topic of the time. So vote carefully and vote once.
Is that an official rule, Ben? You can only vote once?
Yeah, I don't know. I was going to say vote early and vote often, but that didn't sound right. I don't know.
Okay, I'm excited to see how people are going to answer. All right, so let's see, Tracy. Oh, okay, interesting. So 56% said implement TTM with a goal of 32 to 34. The second most common answer was 28% of you said implement TTM with a goal of 36. 10% of you said you wouldn't do any temperature management. And then 6% said aggressively avoid fever. Okay, Tracy, thank you so much for those results. So we are going to chat about the recent literature. So why should we manage temperature? So Ben, you ready to kick it off and let's talk through the literature?
I am ready to go. So yeah, and so I should tell everyone a little bit of context. This notion of cooling people after cardiac arrest, which is now known more broadly as targeted temperature management, or TTM, it's actually been around for quite a while. I could do a whole lecture on the history of the thing. It's a fascinating history. But suffice it to say that for about 20 years now, it's been used clinically after cardiac arrest because of a number of key trials. And we'll go through some of this evidence. the 20 years was preceded by another 20 years of laboratory studies. So this is really one of the most extensively studied things in resuscitation science outside of CPR itself. And the basic framework clinically, as I imagine most of you are clinicians on the call, and you don't want to hear about the animal studies, nor necessarily do I at this point, the clinical framework is you have a period of cooling where you cool patients down, you keep them cold for what's called a maintenance phase, 24 hours, and then you rewarm them slowly over time as well. So this is sort of a typical TTM protocol in hospitals is 3 phases: cooling, maintenance, and rewarming. And this is really being done around the world in clinical protocols that are often baked into EMRs and used and so forth. And they all come from several randomized trials that are now nearly 20 years old, or about 20 years old. One is known as the hypothermia after cardiac arrest trial. The other is by Stefan Bernard and colleagues out of Australia. The first one was done in Europe, second one in Australia. And a third smaller trial I'll mention briefly, also out of Europe. Now, what did these 3 trials do? They all took patients after resuscitation from cardiac arrest, and they randomized them to either cooling or no cooling. And by cooling, they had a target temperature of 33 Celsius, which is about 90 to 91 Fahrenheit, 33 Celsius. So it's not cold. You know, sometimes I get asked, oh, are you freezing people? Well, not really. It's mild hypothermia. And then they looked at outcomes, with the thought being that by cooling people, you can lessen brain swelling, lessen inflammation, and really try to minimize the brain injury that is so common after cardiac arrest. And this is what the temperature curves actually look like in the HACA study. You see cooling, then maintenance and rewarming. And you'll notice there's 2 temperature curves here. The lower one is the interventional group, meaning this is the group that got actively cooled. And because this was a randomized trial, they also had a normothermia or control group, and that's the upper curve. And you notice they started out a little cool. When you've been in cardiac arrest for 15, 20 minutes, you often come in at 35, 36. You've all seen this clinically. And then patients sort of warm up. Now, one of the very common phenomena after cardiac arrest is people get fevers. We call these neurogenic fevers. Neurogenic fevers are one of the most common things after cardiac arrest, and they are a serious problem. These fevers are not helpful or normal. They're from brainstem dysfunction, and they can lead to a lot of secondary injuries. So you may notice that this normothermia curve sort of creeps up towards 38 there. Some patients had fevers, and we'll get to that a little bit later. So why don't we keep rolling with some of the results from all of this. Oh my goodness, and wouldn't you know it, I'm getting an alert for a cardiac arrest while we're on the call. So Nicole, you may not know this, but I have this running joke with my team. Cardiac arrests always come in when I'm giving a lecture. It's incredible. If I gave more lectures, there would be more cardiac arrests in the world. I'm the most dangerous speaker known to the world. So my team will respond, but this will create some interesting challenges here. Let's see if we can keep it rolling. All right. So these are the data from the 3 trials that I mentioned. And if you just want to focus on the red percentages, there's a big jump in survival in these studies when patients got cooled. And importantly, the red percentages only include people who had neurologic recovery. So these are people who woke up. These are people who did well. After all, I think all of us as clinicians, we don't feel good if we resuscitate a patient, keep them alive, but they go trached and pegged to a chronic care facility with no neurologic responsiveness. That's not good. That's not what we all desire in our clinical care. And so these studies knew this, and you had to have a CPC 1 or 2. That is, you had to be walking and talking, a cerebral performance category of 1 or 2. And you can see in all 3 studies, different investigators, different protocols, big improvements in survival with cooling. And then in the HACA study, they looked 6 months later because they want to say, well, is this a temporary benefit or do patients do well long term? And they found that indeed all but 1 patient were alive at 6 months. So I think one of the key take-home points I want to leave you with today, and I'll sort of signpost some key take-home messages. One of them is a sense of optimism. If we can get people to walk out of the hospital after cardiac arrest, they can do really well. And we have an alumni club of sorts at Penn where we have some survivors who are 5 years out, 10 years out. We stay in touch with them and help them out as they go along. And I got to say, it's one of the most humbling and gratifying parts of my career is having this large family of people who have gone on to live their lives. Some have gotten married, some have had kids, and they all at one point were dead. So it's really quite amazing. And maybe we can move to the next slide.
Yeah, and Ben, we saw the same thing because we started this protocol in 2002 and saw so many wins that we just hadn't previously seen. Now, in those
Yeah.
initial trials, Bernard and Hoppe, they compared a temperature target, 32 to 34, to no temperature control. That was in shockable rhythms. So what are your thoughts about non-shockable rhythms like PEA and asystole?
Yep.
Or
It's an
hospital
outstanding.
as well?
Yeah, it's an outstanding question and one that comes up all the time. For context, as many of you know, there are many rhythms of cardiac arrest. One of them is ventricular fibrillation / ventricular tachycardia, but there are other rhythms as well, and PEA and asystole are also rhythms of arrest. The initial studies really only looked at shockable rhythms. And so for a decade or more, the big question is, well, if a patient doesn't have a shockable rhythm, what do we do then? Does it matter to cool? And believe it or not, it took till 2019 to finally do the randomized trial, a rigorous randomized trial to look at other rhythms. And you see here on the screen that very study. It's known in the literature as the Hyperion study. It must stand for something. But this study looked at cooling specifically for patients after PEA and asystole. And they randomized patients to 33 versus 37. You see the temperature curves here. As you'll see later, it's too bad they didn't do 33 versus 36. And if that doesn't make sense, we'll get to why that makes sense. But this is what they did. They did 33 versus normothermia. And then they wanted to look at outcomes to ask the question, does cooling work for PE and asystole arrests? And so we move on to the next slide. And you can do the next click, Nicole. Yeah, there you go. So just to show you who they enrolled, it was a lot of asystole and PEA. So exactly what they tried to get at. Now, some people had unknown rhythms. In the field, these arrest situations are often quite messy. But suffice to say that these are really sick people. Asystole, as we all know, is not good. And pulsatile electrical activity is also not easily treatable often. So these were patients with much lower survival. And the authors reasoned, well, they're often sicker, so maybe cooling might have more benefit. We see this a lot in critical care, of course, that sometimes you got to be more aggressive with the people who are sicker. Next slide. And so on the next slide, you can see the outcomes. And there was a statistically significant improvement in survival with neurologic recovery when cooled. So it seemed that people did better when they got cooled from PEA or asystole, of course, after resuscitation from PEA or asystole. Now, what's really interesting is mortality was the same. It's just the neurologic recovery was better. And I don't know about you guys, but to me, that's almost like the ideal result. The last thing we want is to say, yay, we improved survival, but gosh, sorry for your loved one who's now, neurologically devastated. That's a tragedy. So it seemed what this therapy did was it took people who were going to live anyway and made them live better. But if you were sadly going to die, you still were going to die. So this didn't save lives, but it saved brains, which is great because more people got home and did well.
And,
so that's
yeah, I think one of the things that really stands out is just the low survival with good neurologic outcomes. I mean, this is profoundly low. I mean, if you just think in general compared to all arrests, right?
Yeah, it is low. So these were really sick people. These were people who, no matter what you did, their survival was low. And that's what we see with asystole. And it's, asystole and PE are kind of like the big frontier because when you have patients with shockable rhythms, at least in theory, if it's a witnessed arrest, you can get an AED in there. There's medications for treating shockable rhythms, amio and lidocaine. So we have things we can do. With asystole and PEA, it's much harder, and asystole is really tough. Often asystole is just a reflection that it wasn't a witnessed arrest or there wasn't bystander CPR, so rhythms sort of deteriorate. So yeah, these are sick people, and this will become really important when we talk about the newer studies that have caused some controversy about temperature. So here's the HA guidelines, and as many of you know, every 5 years, the American Heart Association updates its resuscitation guidelines. And in 2015, there is a strong recommendation for using TTM, targeted temperature management, after cardiac arrest. And that was kept in the new guidelines. So the new guidelines that just came out basically didn't change all that much, except there's a stronger recommendation for non-shockable rhythms because of that newer study. Now, you'll notice that they say a temperature range of 32 to 36. Now, you might be saying, well, gosh, you just told us they all targeted 33. So where are they getting 36 from? And that's going to be where we're headed in this conversation. These two studies out of Europe that have caused a lot of controversy about whether to cool to 33 or manage at higher temperatures. But we will get to that very shortly.
Yeah. And so we knew from those early studies that 32 to 34 definitely worked for shockable rhythms when compared to doing nothing, meaning no temperature management. But like, what about, okay, so if 32 to 34 works, the question is, would a higher target work where maybe we might have less side effects? So let's explore the TTM trial that was published in 2013.
Yeah, and so this is where things got really interesting. Before 2013, it seemed like the science was pretty cut and dry, and all of the hospitals around the world had these TTM protocols where if you got somebody back from arrest, you'd cool them to 33. There's equipment, and manufacturers would make cooling devices. Everything was like nice and tidy. But, you know, life is never quite as nice and tidy as we'd like it to be. And here's an example. This group out of Scandinavia asked the following question. They said, gosh, you know, cooling seems to be dandy, but it's a bunch of work. There are some side effects. My opinion is they're not all that big a deal, but patients can shiver. Patients can get bradycardic. Some patients bleed a little bit more. These are all actually very, very low risk side effects, but nonetheless, there are some side effects. And they said, well, if most of the injury is from fever, maybe we don't care about cooling to 33. Maybe we just want to aggressively avoid fever. And so they enrolled groups into two populations, one that they cooled to 33 and one that they managed at 36 using cooling devices. So the same technology was used, but they just said, you know what, let's just manage them at 36. Maybe we don't need to cool them. We avoid shivering, maybe. We avoid bradycardia. We avoid some of the bleeding. Now, it's important to look at this chart a little bit because this population is very different than what we all see in the United States and what many of you see. The witnessed arrest rate was 90%, nearly 89 and 90. I don't know about you guys, but at my hospital, we have about a 30 to 40% witnessed arrest rate. And by witness, that means someone literally saw them drop. If someone dropped in the kitchen and someone else comes down the stairs from the bedroom and finds them on the floor, that's not witnessed. We have no idea how long they were down. And the bystander CPR rate was really, really high as well. So it was a 73% rate of bystander CPR. In the U.S., and at least in Philly, we have like a 20 to 30% bystander CPR rate, so much lower. So just file that away as we go deeper into these things. Next slide.
Well, and I think the other thing is most patients were shockable rhythms. And it's not a criticism, but I think that's one thing you have to know when you look at the results.
No, I think that's exactly right. It's also shockable rhythm. So these are just very different patients than what was seen, certainly in the Hyperion study, but also in some of the other experiences of hospitals around the world. Okay, so that is where things were at. And here's the survival curve from this study. And you can see that when patients were measured 33 or 36, the survival was the same. And this was quite a shock, let me tell you. When this came out, it was like a tidal wave, or I should say an earthquake. That would be the better analogy. People said, well, you know, we've been spending 15 years cooling people. We've had protocols, we have devices. You know, what do we do with this information? You know, why would this be the case? And I was there when this was presented, and one of the active areas of discussion, which I still maintain is true, is that this was not that sick of a population. These people had witnessed arrests, shockable rhythms, lots of bystander CPR. This is in Scandinavia. It's a very different population than what we see in the U.S. So maybe it's just different. Like maybe these results are true for that group, but not true for everybody. And so the real question raised here, and I show you here the Hack and Bernard studies, and this is sort of the summary of the data I showed you earlier, with real improvements in survival, but with this newer study by Nicholas Nielsen et al., which is known as the TTM study. Actually, now we call it TTM1, because we'll get to this in a little bit. There's a TTM2, but in the TTM1 study, survival was the same. So these are really different results, right? You can see this graphically. They look really different. What is interesting now is survival when you clamp the temperature at 36 is much better than survival with no cooling whatsoever in the Bernard and Hacka. So it seems that temperature management still works. And the investigators of TTM would never say TTM doesn't work. They just say you can do TTM at 36. But why is it so different? Like, what's going on here? and we go to the next slide, we'll get a clue on this. These are the temperature curves from, on the left, the Nielsen or TTM study, on the right, the HACA study. And I've made the axes exactly the same, so they're directly comparable. You see 32 to 39 is lined up nicely on both. And you can see that by design, the Nielsen study was at 36. Not by design, but just sort of by the way it worked out. As we mentioned earlier, patients often get fevers. In the HACA study, they did no temperature control, and it was 37.6. So these are really different studies, and they can't be directly compared. In the HACA study, there was a decent amount of fever. In the Nielsen study, there was no fever. So at least this supports the notion that at the very least, aggressive fever avoidance, at a minimum, is super important in post-cardiac arrest care, and that maybe aggressive temperature management at 36 is okay. So this was the raging debate from 2013 till today. The point I would make, and this is another sort of key take-home point, is if anyone says the 2013 TTM trial overturned TTM and said we don't need to do TTM, that's not correct. It wasn't saying that TTM doesn't work. It's just saying you could do active temperature management at 36 and probably have the same benefit. That's a fair interpretation. But you would be amazed. So many hospitals around the world said, you know what, throw out that equipment. It doesn't work. We're not doing it anymore. And that's an incorrect read of the literature. And many patients were subjected to post-arrest fevers and worse outcomes.
Well, and actually, you could make the point that we proved that throwing out the equipment and not managing temperature doesn't work when we in the HACA and Bernard trials, right? Because they were basically comparing a temperature target to not controlling temperature at all.
Yep. And that's the thing. Yeah, targeting and not targeting are just like very different things. That's right.
Yeah, absolutely. So we look at this data and we've got kind of this building body of literature. So now the question everyone's asking is really maybe the key here to just avoiding fever altogether. And that leads us to the TTM2 trial, where they compared 33 degrees versus fever avoidance. All right, let's chat about this one, Dr. Bella.
Yes. So this just came out this year, so it's really hot off the press. It was the same group. And, you know, when they did the 33 versus 36 and they found the same results, they said, well, gosh, you know, we didn't push this even far enough. Maybe we don't even have to do 36. Maybe we can just avoid fever. And they set this, they had a sort of a funny protocol. They said they had to keep the temperature under 37.8, but if it climbed above that, they would do aggressive temperature control to keep it under that, but they didn't have to initially. Now, in reality, if that sounds confusing, it is. In reality, most of the patients got a temperature control device in both arms anyway. This is sort of a pragmatic trial where sites could sort of do things how they wanted to. It was a large study, so they felt it was really difficult to really enforce a protocol. But the bottom line was they randomized patients to 33, or this fever avoidance protocol where they kept people under 37.8. And I show you Nicholas Nielsen. He's a neat guy. He's in Sweden. And it was a well-done study, but that's okay, Nicole, the next slide is fine. It was a well-done study, but let's go a little bit into who they enrolled. And you'll see it's a lot like TTM1. So again, the theme, an enormous rate of witnessed arrests. I didn't put it on the slide here because it wasn't in their slide presentation. This is taken directly from their data, but it was 90% witness, and it was 80% bystander CPR. So a really high rate of bystander CPR once again. And, you know, I wish we could have bystander CPR rates of 80%. I would challenge any of us in the United States on this, that there's, you know, we just don't see that. And again, a lot of shockable rhythms. So the population in the first TTM study, TTM1, and TTM2 looks the same. And perhaps not surprisingly, they had the same outcomes. Now, before we move on from the slide, I want to point out a couple other things. Notice the rate of cardiac cath. 78% of all their post-arrest patients got cath. Now, I don't know about you guys. I wish we could get that many people to the cath lab. Our cardiologists tend to not be so active on that. And the PCI rate is very high too. 38% got an intervention in the cath lab. In the United States, on average, about 10% of post-arrest patients get an intervention initially, so 4 times higher. What does this mean? Honestly, I'm not totally sure. What it certainly means is that many more arrests in this setting mostly in Scandinavia, had their arrests from acute coronary lesions. That's the only conclusion I can come to. Now, why that's the case? Gosh, hard to know. I think one of the reasons why is many arrests in the U.S. are from old scars from old MIs and also from small vessel disease that's not intervenable. So again, it speaks to the fact that I think that there are just many differences between these populations. So anyway.
Yeah, and I think when you look at these, just the characteristics of the patients, you've always got to ask, like, how is my system, or how are the patients we are seeing, how are they different? And this is a very high shockable rhythm rate. It's just, so basically they mostly studied shockable rhythms in TTM2.
Yeah, no, that's right. It was mostly shockable, and it was just a very different population. Now, my opinion, and what I'm going to now talk about is my opinion. I'm always very careful to point out what's science and what's opinion. But there's a number of studies that have, there's a number of investigators that tend to agree with this line of logic, which is that it very much depends. I'm getting a little feedback. I don't know if you're hearing that as well somewhere. Maybe someone's sound system is on. In any case, there's lines of evidence why we might want to be a little skeptical of directly applying the results of TTM2. And I got to say, I'm really encouraged by the audience that many of you answered continued cooling. I tend to be in that camp as well, at least in the U.S. You're not wrong if you said manage at 36 or 37, and that's why it's a debate. There's no wrong here. But here's the reasons why I think a wholesale uptake of the TTM2 protocols may not be a hot idea. One, there's a lot of evidence from the laboratory that TTM works, and we know why it works. Also, there are multiple positive RCTs that show that TTM to 33 works that we'd be throwing out if we switched. I think the most interesting thing actually is number 3, which is the real world experience. RCTs are a funny thing. They're done by investigators. They're done in research-oriented hospitals. As an ER guy, I like to live in the real world. I like dirt under my fingernails. And I've learned over the years that the real world is just a different place. And some of the rules that seem to apply in RCTs don't kind of work in the real world. And I'll share with you some real world stories of how hospitals switched and their outcomes worsened. And then finally, I think it may have to do with patient selection. And that, I think, is the sort of key take-home point, that it may not be, do we do 33 or 36 or 33 or 37, but it depends. It might depend on the patient. Next slide. Yeah, whoops, let's go back. Here we go. So just briefly, just to give you a taste, here are some animal studies. There are hundreds of animal studies I could cite that all looked at temperature management in laboratory models of cardiac arrest. And it's very strong literature that shows that TTM works and shows why it works. They show reduced brain swelling, reduced inflammation. So there's mechanisms of disease. And it's really powerful in an animal model when you can show that something works and you can say, and here's why it works, so we know there's a reason for it. Next slide. But I don't want to dwell on the animal stuff. I think I just want to remind you that there are these 3 positive RCTs. The last one is the Hyperion study in France, which I showed you a little bit ago, the non-shockables, and then there's 2 shockable ones. And so, you line up these 3 studies, it's pretty compelling evidence that the TTM studies disagree with, but they certainly don't show that 33 is worse. They just show it's equivalent. Next slide.
So in 2013, yeah, so there were a lot of, after the 2013 TTM trial, I felt like there was a lot of misconceptions about that trial. And I always joke around, like, I think people read the abstract and don't read what's actually in the study, the details of the study.
Yeah, absolutely.
A lot of people hung the coat up on TTM in 2013. And but some of us stuck with it, and some of us went to 36 degrees. So let's chat about that, because a lot of us were cooling early at 33, and then a lot of us switched. And let's chat about what happened after that.
Yeah, that's right. And this is when things got interesting. And I think for clinicians, these data, I think, are the most interesting and intriguing. So this was a hospital in Melbourne, Australia, that said, okay, the TTM1 study showed that 36 was enough. We don't need to cool. So let's just switch. Let's just switch to 36. They were brave enough to publish their results. And what they found was survival worsened. People did not survive as well at 36 or 33, and they've switched back. So they said, oops, this was a mistake. Now, why was it a mistake? We'll never know for sure because it's a retrospective study, but, they found that more people got fevers. They found in general care was less aggressive at 36. So whatever the case was, they had fewer survivors when they switched to the TTM1 protocol. And I think most simply and most fundamentally, this speaks to the difference between doing something in a laboratory type condition, that is a randomized trial, or just like implementing it. And when you implement it, you have real world practitioners and real world conditions, and things are just different. Things are different. So anyway, so that is one of the issues. And here's another study that was of a similar nature. So this was out of Seattle, out of Harborview Hospital in Seattle, and Nick Johnson, one of my former mentees, very proud of him, led this study where they basically did the same thing. The hospital switched after TTM1. They said, you know what, we're going to 36. And again, the same finding, survival dropped. So they had fewer CPC1 survivors as before, and they switched back. So now we have two different continents, two different groups of people, two different studies, pretty much the exact same results. But this switch tended to do bad things and tended to worsen outcomes. Again, we'll never totally know why, but it worsened outcomes. And this is problematic. This is something that I think as clinicians, we all have to worry about. And if we do the switch based on TTM2, aren't we just going to find the exact same thing? That's what I worry about.
Well, and this is the hospital. I wrote the initial protocol back in 2002 and was worked with patients after the switch. And, when we targeted 33 degrees, we would literally put the pads on the stretcher from when EMS came into the emergency department and get the pads on right away. But, now you've got EMS bringing patients in who are presenting with a temperature of 36. So you're like, okay, we don't need to do anything. And then by the time they get up to the ICU, they've got a fever. It's challenging.
Yeah, no, it really is. It's really challenging. And we know these fevers are bad. That's the thing. Like we are certain that fevers post-arrest are bad. There's a lot of evidence for that. And so this next slide to me sort of is sort of this 10,000 foot philosophic view of this whole thing. And this has been seen, those of you who have been in practice for a while have seen this with other therapies as well, like goal-directed therapy for sepsis. There's a natural rhythm, a natural cycle to medical science. Something comes out that shows, wow, this new therapy X is amazing, and in our case, TTM, and that we should do it for everybody, and that's great. And that's like uninformed optimism, according to this. I didn't make this the curve on this, but I love the term, so I grabbed it. And then studies come out saying, no, that didn't work. It was all wrong. And you get to this like depression where you're like, you know what? Were we just doing things wrong the whole time? Were we just led down a false pathway here? And then it settles out. New science comes out and says, look, life's never that simple. It works for some people, not for others. So it gets muddy, and none of us like muddy, but like the world is muddy, and certainly critical care comes in a lot of different flavors. And so this is really, I think, the best visual summary of this concept. Everyone loves to go down the path of simple, right? We like simple. We see this in and not to get political, I won't, but in our politics, we have these simple soundbitey messages and people just love them, But the world is complicated. Now, in human discourse, that's like boring and it's like TLDR, too long didn't read, But the world is complicated and answers are complicated. And so it's a less traveled road, but sometimes it's the correct road. And that'll take us to our next thing, which is really the issue of patient selection. And this, I think, is going to be the way forward. This is some new stuff. I'm going to share with you two studies here that have just come out in the last year or so. This is from my Pittsburgh friends, Cliff Calloway and colleagues. They basically looked at the severity of injury in patients after cardiac arrest. And I won't bore you with the numbers. They had a sort of a way to categorize injury. But the bottom line is really important. They found that the people who are less injured, more bystander CPR, shorter downtime, less evidence of organ dysfunction after arrest, the less sick ones did just fine at 36. The more injured ones, longer downtimes, asystole, showing AKI, acute kidney injury, showing brain swelling, they did better at 33 than 36. So this is really, I think, a key message, that it really matters whether how sick a patient is. And in this way, it's a beautiful way to tie together the whole field. It's not that the TTM1 and 2 studies are right or wrong. I think they're right for the people they included. It's not like the Hyperion, Hack on Bernard studies are right or wrong. They're right for the people they included. This study And the next one I'll show you suggests they're all right. It depends on the patients. This was the same sort of thing out of Japan. They looked at severity of injury using a different scale. They used something called the RCAS scale that was specific to their group, but we don't use that one. But suffice to say, they found that the sicker the patients were, the more they benefited from 33. So if these two studies are true, there's a very clear message here, which is you got to sort of look at the patient population that you're treating. If you're treating a population of mostly witness VFib patients who have short downtimes, go for it. Normothermia or 36 may just be fine. If you're treating people like I do at Penn with like 20, 30-minute downtimes, maybe only some of them have bystander CPR, even when they do, it may not be so good, and they're densely comatose after rest, I don't know. I want to do everything I can for those people. And because there's not a single study showing that 33 impacts harm in a significant way, that is regarding survival, we say, gosh, why not do it? Why not be aggressive and try to help these people out? So that's sort of where I think the field is going. And here's a slide that really takes this generalizability to heart across a variety of studies. So on the left, you see the TTM2 study. As we've mentioned, high bystander witness, 90%, lots of bystander CPR, mostly shockable. And look at the survival, 50%, 51% survival. Most U.S. hospitals do not have that. These Scandinavian hospitals, they're doing something right. Now, on the right is the best apples-to-apples comparison. Two studies, large post-arrest care studies out of the United States. Lower bystander CPR, lower witness, much lower shockable, and lower survival. So something is going on here in the U.S. patients, and I would suggest it's because they're sicker, less bystander CPR, longer downtimes. They're sicker, and so they just do less well. The other thing that's buried here, it's not really reported, but it's important for everyone to know about. In Europe, the places where they did TTM2, most of the EMS systems have a very strong culture that they only transport if they get you back. In many centers in the United States, most, they may transport you even if they haven't gotten you back. And so the people who would have been exposed to cooling in TTM2 are less sick because they got them back in the field. The people who they got back in the U.S. studies may have been resuscitated in the ER with longer downtimes. So it's really hard to do a direct comparison. And so in my opinion, the TTM2 study is really tricky to interpret for the U.S. arrest population. To sort of summarize, actually go back if I can, Nicole, I'm sorry. So to summarize, I think that in my opinion and that of others is it's hard to wholesale abandon a therapy that has great laboratory evidence, strong RCTs, and I just worry about those real world lessons that if we switch, we're going to see worse outcomes. All right, now we can go on to that next slide there. There's a lot of other things we could talk about, and we'll talk about briefly, because these are questions you may have discussed in your hospitals. Like, for example, should we cool for longer? I'll tell you that in animal studies, the injury to the brain goes on for days following cardiac arrest. So the question is 24 hours of cooling enough? Well, this was a randomized trial looking at 24 versus 48 hours of cooling. To answer that question, if longer cooling would be better. Next slide. And what they found was that it didn't matter. 24 hours was plenty long enough, but there was a trend towards improved survival of 48 hours of cooling. So how do I interpret this? At least 24 hours of maintenance cooling is appropriate, but I don't know. If this study had been twice the sample size, it would have been significant, and all of us would be changing in 48 hours. So it makes me wonder if there's a benefit from additional cooling. I'm not saying you should run home and do that, but it's to me, it just strengthens the argument that cooling is doing something good. Next slide. Now, the other sort of key question that's very clinically relevant is when do you start this thing? Can you start it in the ICUs? Could you have to start in the ER? And I believe pretty firmly that in 2021, when most patients are stuck in the ER waiting for ICU beds, and many of you, I'm sure, are nodding your heads going, yep, that's the case in our hospital. Getting ICU beds is really tough, and they sit for hours in the ER waiting for beds. You just can't wait. In the old days, maybe you could wait till they go upstairs from the ER, but these data support the notion that the timing matters. And this is a study that looked at door to cooling initiation time, sort of like door to balloon time for STEMI, but door to when they started cooling. And the question is, does it matter if there was a delay? And this was a large retrospective study. And what they found on the left here was, this is just the real world example of when people got their cooling started. Many people got cooling started within the first couple hours. That's great. But you can see many did not. Many took 3, 4, 5 hours to get cooling started. And so some even longer. and they asked, did this matter? And they adjusted for illness, because you could imagine that if you got started later, maybe because they're really unstable, that might make them look sicker. So they adjusted for these things. And they basically found there was a survival benefit if you got cooling started within the first 2 hours. So our general recommendation is if you hit the door of the ER, a clock starts, and you really want to, sometimes it's not possible, but you really want to shoot for getting the pads on or the catheter in or however you're cooling, you want to get it started before the 2-hour mark if you can, because there's evidence now that this improves survival. So hour one is sort of getting the story, getting the patient central lines, getting head CTs and ECGs, that initial sort of workup. And then hour two is moving towards cooling. That's sort of the ideal time frame for management of these patients. Next slide. And so there's other aspects too that go into this whole thing. For example, bundling things like mean arterial pressure goals, MAP goals. You know, AHA teaches you have a MAP goal of 65 millimeters of mercury or higher to maintain brain perfusion, because a lot of these patients have brain swelling. Also, you want to avoid early withdrawal, and we'll touch on that a little later. Very important point. So this is work from our hospital where when we combined these things into a bundle of post-arrest care, we were able to greatly improve survival and neurologic recovery as well. Next slide.
Yeah, you know, Dr. Bella, I feel like this is the area that really needs like a deeper dive in research, because we don't know the optimal MAP target, and I mean, there's just so many unknowns about hemodynamics post-arrest, and I just feel like this area needs so much more research.
I agree. Absolutely, Nicole. You're spot on. I think that, you know, the field is focused so heavily on this temperature thing, almost like obsessively, but there's a lot more that goes into good, high quality post-arrest care than just the temperature selection. And that those other topics like mean arterial pressure goals, oxygenation goals, pH goals, they've all sort of been pushed aside, really, or not studied as much, and they may make just as much impact. So, for example, there's some evidence that having patients get too much oxygen may be bad following cardiac arrest. We haven't had time to talk about that today, nor will we, but you should know that it's still an open question. Some people think, oh man, we want to avoid too much oxygen. Some people say it doesn't matter. And just like that, I agree with you, mean arterial pressure goals, there's a lot more science to be figured out. And so this is getting to the point of early withdrawal. And I think, you know, as a take-home point, this is like my third or fourth key take-home point. If you're going to do one thing in addition to TTM, one thing, it's coach people to avoid withdrawing patients early. Early withdrawal is a big no-no in post-cardiac arrest. And what do I mean by that? This is a study from our group, and others have done this as well, where they look at when people wake up after cardiac arrest. So we just asked a really simple question, like how many days does it take to people wake up? And you can see that it takes a while, 3, 4, or 5 days before people wake up. And so this reinforces that you really need to delay withdrawal. And the AHA teaches, and I think it's on the next slide, and that's just showing the time frame, that the AHA teaches, and the guidelines are the exact same on this in 2020, that you have to wait at least 72 hours after arrest, and maybe even a few days longer, because if you've cooled them, they're sedated, perhaps even paralyzed, before you can neuroprognosticate. And this is based on the clinical bedside exam. So here's what I mean by this. If you examine a patient and they're comatose, and they have no gag, and they have blown pupils, for the first 3 days post-arrest, that may not mean anything. And withdrawing care, saying, oh, they've got blown pupils and no gag, you know, it's not going to work out on day 2. That's inappropriate, because many of these patients still go on to survive. In fact, a newer paper just came out this month looking at this in Asia, and they found that 20% of patients woke up after 5 days. So confirming what we already knew, but really making home this point that you got to wait. These patients, you know, brain recovery is a little bit magical, a little bit poorly understood, and it just takes time. So you can save the most lives if you just give patients some time, be patient. Now, of course, this is really hard because all of our ICUs are full, and especially with COVID. And so telling everyone to wait, you know, and pick up an ICU bed is a real challenge, but we have to advocate for the patients in front of us. You know, we got to leave the systems problems to the bean counters and the CEO types. The patient in front of us is our business. And if you have a post-arrest patient, they need time.
Yeah, I mean, otherwise it becomes a self-fulfilling prophecy, you know, if we withdraw. Because we late wake-ups. I'll never forget a patient on day 13, post-arrest, opens his eyes and starts looking around, mouthing, where am I? So it's just, you have cases like that where you just shake your head because his wife is who advocated for him to like, for us to wait, please wait 3 more days, just, and it was insane. It's kind of a crazy
Yeah, I'm
thing.
curious,
So
Nicole. When you were doing your thing at Harborview, would you feel sometimes the pressure to get these people moving? Like, hey, it's day 2 or 3. Like, let's make a decision. Or were you able to sort of fend off those forces?
I mean, it depended, right? Like, it depended. A lot of times, I will say though, the families who spoke up and asked for more time got more time. And I mean, I think that's such a precarious place to put a family in as well, because they're not, they don't have the medical background and know. But I have to say, having neurology involved is, I feel, an absolute must in programs.
Yep, I think so. And I think, this is one of the reasons why this topic is so hard, and I also think so fascinating, is it's really multidisciplinary. I mean, this hits medicine at its weakest spot. So medicine is at its weakest when we talk about collaboration across specialties and a collaboration across nursing, doctor, pharmacy. We all do pretty well in our own little silos, but when we have to work together, which is my favorite part of the business, that's why I went into emergency medicine, where teamwork is really sort of big, as in critical care. But when you talk about ERs collaborating well with ICUs, and cardiologists collaborating well with both of them, and neurologists collaborating well with all 3 of them, it's tough. And then you've got sort of the nursing care issues and protocol development versus the physician goals versus the pharmacy needs for sedation and paralysis and the cooling effects. This is really, at its heart, a really multidisciplinary sort of issue. And so, how we work forward is as a team, and it's hard. It's hard, which is why I think this field is so important and so challenging.
Yeah. And then, so Dr. Bella, we're going to wrap it up. Can we just go over, can we limit it to 1 minute to talk about what role EMS has in TTO?
Yep. Yeah, and it's easy to do in a minute. The bottom line is not so much, unfortunately. I say unfortunately because you'd think earlier would be better. So there was this question of, would cooling earlier make a difference? After all, I showed you data that suggested it might. So if you cooled in transport, could you shave off a couple of hours and get cooling started earlier? Well, this was tested, and on the next slide you'll see a summary of some of the key studies here. And bottom line is, didn't work. So they all gave cold fluids in the field. None of them worked. It just didn't improve survival. And I think the bottom line is, in most EMS transport times, it's like 10, 15 minutes. It's just not going to make that much difference. Also, the ability to pump people full of fluids may not matter. Now, here's where it gets really interesting. What if you cooled even earlier? Click the next. There's an animation here, Nicole. There you go. And you cooled during arrest itself. What would that do? What would that look like? And this has been tested in animals and found to be highly successful. There's something about cooling during arrest that's really, really biologically powerful. Well, if you didn't think this would be possible, there was a study presented and published, but I like using their presentation slides, called the Princess Trial. And this was done in Europe, where they cooled people with this, there you go, with this nasal cooling device that could rapidly cool the brain. And they found a trend towards better survival. It wasn't statistically significant, much to their sadness, a trend towards improved survival when they cooled intra-arrest, during arrest itself. Now, we're not doing that clinically. It remains to be seen, a lot more science to be worked out, but I think it's really interesting and compelling, and we may be headed that direction. So the bottom line, EMS right now does not have a key role in cooling, except to get patients stabilized and get them to the ER as quick as they can. And we can just skip that slide. That's not so...
Okay. All right.
Yeah. And so I think, one of the things I would say is, this is a hard field. And, I really applaud our sponsors today and organizers, and you, Nicole, for guiding us through this discussion. I think this is an important topic. It's a life and death topic. It needs more time, needs longer treatment. And we've noticed over the years a real implementation gap. There's good science out there. There's important guidelines. There's excellent technologies to deliver these therapies. But yet, wherever we go, there's confusion, there's challenges with protocols. And so how do we bridge this gap? Well, we started something at Penn called the TTM Academy, which is basically an educational platform to support use of TTM in high quality post-arrest care. We have free podcasts, we have infographics, we have links to key literature, and we do courses. And I think on the next slide is an example of one of our courses.
No.
That's okay. I can just say it. So, no worries. Twice a year, we do, it used to be live, now it's online, which, plus and minus. It's actually better because more people can join us. We do one-day workshops all on post-arrest care implementation. So, like, how do you manage the cath lab? How do you manage EEG? How do you put it all together into a protocol? Our next one's going to be on April 1st. Friday, April 1st. You can check out our website or follow us on Twitter if you like. Our website is penttm.com. I think there's a thing up there as a placeholder for our April 1st next course, but you're welcome to join us for that experience as well. All right. I think with that, I have said everything I can say in an hour.
Thanks so much, Dr. Arbella. So we're going to hand it back over to Dr. Simmons, and he's going to give you some information on CEs, and then we're going to take questions.
You got it. And I will try to get through our CEs and archive stuff as fast as I can because we only have about 4 minutes for questions. So as you can see on your screen there, this is good for continuing education for nurses and respiratory therapists. It's been approved for 1 hour. Directions are pretty specific. So you need to go to www, and for this website, it is important to put that in there, www.saxtesting.com/SL. Register on the site, finish the evaluation form, and then once you're done with that, you'll be able to print your certificate of completion, okay? Of course, as Dr. Arbella mentioned as well, we wanna thank Stryker for their educational support of this activity. As well, there is an archived version. A couple of folks asked this early on. Hope you're still around. There is an archived version of this that will be available at savinglivesnow.org. The on-demand version is accredited for nurses and respiratory therapists for your CE. Hey, it's very exciting. So if you didn't get to finish this, you can go back, watch the archive version, get your CE credits. Okay, so we only have about three and a half minutes for questions. And so I kind of wanted to bucket them a little bit because there were sort of themes that kept popping up throughout this. One of them, and I'll start with this one, it's a little bit tricky, Nicole and Dr. Bella. Comorbidities related to survival in the TTM trials came up a couple of times, as well as were there particular comorbidities that showed a greater propensity or better outcomes regardless of the cooling temperature. So even if we were at 36 and then we went back to 33, were there sort of comorbidities that stuck out more that had either worse outcomes or better regardless of temperature?
Yeah, it's a really great question. And yes, there were some, but the problem is they weren't very predictive. And I'll explain what I mean. So certainly age tracked a little bit. Younger people tend to do better, older people less so. More importantly, people with known kidney or cardiovascular disease tend to do less well. But here's the problem. At the individual patient level, there were plenty of people who were older with comorbidities who did great, and plenty of people younger who did less well. The two biggest predictors, and I think this is true across all cardiac arrest studies, the two biggest predictors are bystander CPR and witnessed arrest. So regardless how old you are, regardless whether you've had injuries to the heart or brain in the past, if you get prompt bystander CPR in a witnessed arrest, your chance of survival is hugely improved compared to not. So it's really important for any of you out there who are ED practitioners. I think a really important practical question, you got to ask your EMS crews, hey, was this a witnessed arrest, yes or no? Was there bystander CPR, yes or no? Now, sometimes they may not have a clear answer on that, but you got to ask because those two things really influence outcome more than anything else.
I'm just gonna say 100%, and that's one of the things I preach constantly is the question you should always be asking: was it witnessed? Was there bystander, and what was that initial rhythm?
That's huge, and I that really kind of ties in really well. There were a lot of pre-hospital questions, particularly if cooling made a big difference. You kind of answered those at the end there, so I'm gonna let that stand. But just know your audience was really interested in a lot of what was happening with pre-hospital, both during arrest and then in EMS, and then even cooling on the way into the ER. There were some really specific questions there. So I think there's a lot to be learned from that. This one I find really super interesting. This was asked 4 or 5 times. There's some folks who are doing continuous EEG monitoring during cooling. And I think you touched on this a little bit, but did you see particular differences in outcomes related to this? And was it involved in either Hyperion or TTM trials?
Yeah, so EEG is such an important topic in this whole field. If the bottom line is, if your hospital has the capability to do continuous EEG in these patients, I'd recommend it. Many hospitals in the U.S. still can't do that. It's expensive, it's hard, you need techs, they have to be on call. It's not easy, but it's so helpful. And the reason why, the biggest thing I can tell you about EEG is up to a quarter of post-arrest patients have seizures or some seizure-like activity, and you want to catch it because we have treatments available. One study that I think needs to be done is whether prophylactic treatment with anti-epileptic medicines post-arrest makes an outcome difference. We don't know. The bottom line is EEG is important, and we generally recommend getting it hooked up within 6 hours of arrest. Now, sometimes that's just impossible, and it's an aspirational goal. But the sooner you get it hooked up, the sooner you can treat seizures. And there's some evidence that treating these seizures aggressively helps. The other thing is it can be really helpful for prognostication. Yes, the bedside exam isn't so helpful for 3 days, but if the EEG looks terrible or shows a lot of seizure activity, that's helpful to start setting expectations for families that things are in a bad way. On the other end, if the EEG looks clean, there's no seizures, there's good robust brain activity, got to hang in there. There's a real opportunity to improve outcomes there.
Yeah, and I think one of the frustrating things is we have nothing that predicts you will wake up. We put different tests together that will give us an inclination that you likely won't wake up. And I wish we had that test that said you're likely going to wake up. We just don't have it.
Yeah, wouldn't that be lovely? I mean, that would change everything.
Yeah. We really don't have that, and that's a problem. And a lot of ink has been spilled in medical journals trying to find that thing. It will probably, unfortunately, be complicated. Some combination of EEG and some blood tests and various things. One of these scores that run through the EHR. We're not there yet, unfortunately.
So we have just about 75 seconds. We're allowed to go over just a little bit here. So I'm going to throw one really quick question and then one a little slightly more complicated question. I thought this one was really interesting. Any changes in cooling protocol if the patient is pregnant?
Yeah, there have been only a few case reports in pregnancy. We just don't know, and that's much discussed. The few case reports show that cooling works in pregnancy or is safe in pregnancy. And when you talk to advanced MFM type folks, these folks who do really sick pregnancy evaluations, maternal-fetal medicine, they say caring for the mom is caring for the baby. And so if it improves the mom's recovery, do it. And they would say do it. We have no evidence of any harm from cooling to the fetus.
And that's been my practice as well over the years, yeah.
Very good. All right, last question here, and we thank everyone for hanging out here. We're going to go over just a little bit here in the end. Controlled rewarming, sort of like the next hour-long conversation, but can you, in 45 seconds, can you talk about, particularly folks were asking about clinical indicators for controlled rewarming?
Well, I think one of the key things is using your devices and understanding your devices. All of the devices that are, I shouldn't say all of them, the top devices that are on the market will give you indicators. So for example, like if the water temperature is dropping, that's a sign your patient's likely generating heat. And those are things that the bedside nurse really needs to cue in on. And then I can't say enough, you have to have a shivering protocol, and it needs to be aggressive, to keep the temperature steady and at the target that you want. What else would you add, Dr. Bella?
Yeah, no, I think that's right. I think that many of the temperature devices have protocols for this. Cooling, rewarming should be slow, it should be controlled. If you rewarm too quickly, there can be hemodynamic consequences, other electrolyte shift issues. So yeah, slow. We sort of think 0.25 degrees an hour is appropriate, but most of the devices have that built in, and they work very well to manage slow rewarming.
And there's some animal data that you may negate the benefits if you rewarm too quickly. So, I think the confusion at the bedside comes when you've got a patient who wakes up and is following commands. Like, is that the patient you rewarm slowly? I mean, not usually. Like, if they're waking up and following commands, they're neurologically intact. So, but that does happen clinically at the bedside.
Thank you both so much. This was so good. We could keep going on, right? And thank you for those who stuck around and allowed us to kind of go over by a couple of minutes. A bunch of folks asked, I'm going to repeat these two websites really fast before I hand it over to Tracy. So your CE credits for nurses and RTs, www.saxtesting.com/SL. www.saxtesting.com/SL. And then as well, the archived version will be, you're going to get an email about this as well, but an archive on-demand version will be available at savinglivesnow.org. All right, Nicole, Dr. Abella, thank you so much from your car, no less, from wherever, it doesn't matter. We're here to give you the best education and information. We really appreciate your time, and everyone tuning in. Thank you so much, Tracy.
Thank you, James,
Thank
and
you.
thanks to And thanks to our speakers today. We'd like to thank everyone for attending this webinar as well. And the survey, immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate all your feedback. And the CE certificate of completion, in 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits, which is www.saxtesting.com/SL. And again, thanks everyone for joining, and hope you have a great rest of your day.